Good day, and thank you for joining. I am Sherilyn Francis with the National Center for Primary Care, and we welcome you to our Readiness for Adherence webinar series. Today's topic is the incidence and drivers of insulin non-adherence in minority patients. We invite you to connect with us via social media at PriCare Matters and at www.primarycarematters.org. The National Center for Primary Care at the Morehouse School of Medicine promotes excellence in community-oriented primary care health with special emphasis on underserved populations and eliminating health disparities. Our webinar series is brought to you through a partnership with Novo Nordisk. The NCPC is a national resource for encouraging doctors to pursue primary care careers, for making primary care practice more effective, and for supporting primary care professionals in serving underserved areas. Our core principles are access, effectiveness, and equity. And now a few housekeeping measures. As participants, your microphones are muted and you shall remain muted through the duration of the presentation. For an optimal audio experience, we encourage you to check your internet connection. During the presentation, we ask that you refer all tech issues to the chat pod, and we ask that you refer all presenter questions to the chat pod. There will be periodic stopping points during each segment for question and answer, and there will be time designated at the conclusion of the webinar for discussion and questions. The objectives for today's webinar are to discuss the incidence and prevalence of medication non-adherence among ethnic minority patients with diabetes, to evaluate the social determinants of health which impact medication adherence, and to analyze attitudinal barriers of clinicians and patients regarding insulin prescribing and therapy adherence. I now present to you today's webinar entitled The Incidence and Drivers of Insulin Non-Adherence in Minority Patients, presented by Ms. Sabrina Jackson, Ms. Kati Samos, and Ms. Cheryl Tuttle.
Good afternoon, everyone. This is Sabrina. Thanks so much, Sherilyn, for that wonderful introduction. As Sherilyn said, my name is Sabrina Jackson. I'm actually a physician assistant by training. I'm a clinical instructor, faculty member by appointment, and I like to say that I'm a health equity champion by passion and by calling. And so I'm very pleased to be with you today. Thanks so much for having me. What we wanted to try to accomplish today is really to begin a conversation around this idea of insulin non-adherence and some of the drivers, both from a patient and a provider perspective. The entire webinar series will be a 4-series webinar that's occurring between now and March of next year. So we're hoping that those of you who join us today will be sure to come back as we continue the conversation. As we begin with this first slide, which it's a snapshot, and it may not be foreign to most of you out there. I kind of get the idea that I'm preaching to the choir. But this infographic really captures the weight of diabetes today in America. It currently affects about 29.1 million people, which is about 9.3% of the population, 1 out of every 11 people. What's unfortunate is that 1 out of 4 folk don't even know they have diabetes, and that number breaks down to the tune of about 8 million people. Diabetes costs us annually $245 billion. That's looking at lost wages as well as medical costs. It causes 50% more deaths than deaths that come from other diseases or causes, and actually it's the 7th leading cause of death in America. 2 times higher medical costs when compared to other even chronic illnesses, and it's the leading cause of renal disease and non-traumatic lower leg amputations, as well as new cases of blindness in adults. And so this slide really captures the weight of the epidemic that we now face in America through diabetes. Next slide, please. Thank you. This slide, not everyone may be familiar with it. What was kind of funny to me is that in doing research for this, I found a presentation that says, the CDC has now discovered a diabetes belt. as if it is a wonderful discovery. It's sort of a sombering realization, but in 2011 the CDC coined the diabetes belt. It's a segment of the country that represents 644 counties in 15 states. And what it was necessary for the county to make the list is that at least 11% of their population was diagnosed with diabetes. The diabetes belt definition technically is a geographic area in the U.S. where most residents have a 2 times higher chance of developing diabetes. And I want that just to sink in. Diabetes is an epidemic in this country. Next slide, please. And so like with most chronic diseases, however they affect the majority of the population, when they show up in racial and ethnic minorities, the effects tend to be worse. And so this slide simply shows that when they adjust it for population age differences, looking at the National Health Interview Survey and the Indian Health Survey, National Patient Information Reporting System, this is looking at adults 20 years or older. We can see that initial statement really being reflected. For non-Hispanic whites, diabetes shows up, these are diagnosed cases, about 7.6%. But when you compare that, particularly with Puerto Ricans, it's almost double. And then looking at non-Hispanic blacks, it's not much better at 13.2%. And then a whopping 15.9% when we look at American Indians and Alaska Natives. Again, this is looking at data from 2010 to 2012. Here we are now 4 years later, and you know the amounts of these statistics, we can surmise it's rising, it's going up. And so this slide kind of helps us transition to what we really want to talk about today, is this idea of insulin adherence. So the benefits of taking insulin and adhering to an insulin regimen is that improved levels of glycemic control, reduced risk of developing both micro and macrovascular complications. Insulin adherence, so taking it well so that it is effective, reduces the risk of all causes of mortality and also reduces the economic burden. You notice I place an asterisk on that statement because then we have to also entertain the whole idea of the cost of insulin in America. We may touch on that a little bit today, won't get off into it, but it can reduce the economic burden of the disease. So looking at hospitalizations, lost wages, and complications from uncontrolled diabetes, but we do have to take into account the unaffordability of insulin for a lot of people in America today. And this is a slide that captures some studies that talk about adherence and showing how adherence to insulin can be a problem. There was a study done by the British Medical Journal from 2016, and it simply states that a substantial portion of people with type 2 diabetes just simply don't take medicine as prescribed. Only 67 to 85% for oral medication, and then approximately 60% of insulin doses were taken properly. I would like to add too that the technical definition of adherence is greater than 80%. And so then there is a study also that I really found fascinating from diabetes medicine. It looked at not only reports from patients but also from their providers. And so it talks about that 32.2% of patients reported omitting their insulin at least one day in the last month, but on the average 3.3 days, when 72% of MDs report that their typical patient just doesn't take their insulin as prescribed. And that was a mean of about 4 days per month for basal insulin, just omitting it, and a little bit more than 5 days a month for prandial insulin. 2010, there was a Cook study that reported that persistence with injectable insulin, so up to a year after initiation, so looking at new patients or patients who were new to taking insulin, only 28% of them, of the ones that were queried, a year later were taking their insulin as prescribed. And then finally, a study that looked at about 11,000, a little bit more, of adult subjects with type 2 diabetes, non-adherence to insulin. So that was defined as less than 80% adherence, measured by, having their medicine occurred in just 21% of subjects. So these studies definitely capture the problem that we're seeing, that people are not taking the insulin as prescribed. And then this is just a nice graphic from a study that was done in Scotland between the years of 95 to 2001 of 1,099 patients, and it gave an average adherence rate of being less than 70%. And so we talk about this issue of insulin non-adherence and looking at, those of us who serve patients underserved, who are racial and ethnic minorities, but also sometimes we do have patients that are Caucasian, and because they live in rural areas, they may have issues with access. And so they technically, even though they may not be a racial or ethnic minority, then they qualify as underserved. And looking at this issue of insulin non-adherence, we understand that there are drivers that lead to this. I always like to say when we start to talk about or mention this term, patients being non-compliant, I often will say, to imagine that when this patient got diagnosed with diabetes 10 years ago, that she never said for her the 10th Christmas after the diagnosis that she would love to have a bilateral amputation for Christmas. That's not what she intended when she got the diagnosis. And so when we see our patients who are not adhering to the regimens, one of the things that I want to encourage us to do is to peel back the layers to begin to explore what's going on with that patient that could be driving them there. Because I can guarantee you that their goal in life is not to die a slow, painful death from diabetes complications. So in looking at just some of the drivers for patients, literature reports things like age, regimen complexity, and then psychological factors. This concept called psychological insulin resistance, which is a theory or an idea, is that both patients and providers can have this thought pattern of these feelings that can lead to them, for patients not wanting to take insulin and for providers not wanting to prescribe insulin. So and then we have other psychological factors like fear and just confusion, feeling like they failed because now they're having to take insulin. Somehow I just couldn't achieve what my doctor wanted me to do, and so now I have to take insulin. I failed at doing a good job of managing my disease. There are issues like safety and tolerability, costs, which we already mentioned, patient-provider interactions. There's something about the relationship between a patient and a doctor or provider that literature actually were able to identify that can lead to medication non-adherence. And then, of course, the social determinants. And the definition that we use for social determinants is the conditions under which that people are born, grow, live, work, and age. So many things in the environment that impact a patient that can affect the way they're able to live out their disease. And then if we go to the next slide, what we're also able to see is that not only do patients play a role in this insulin non-adherence and even adhering to other advice, we look at lifestyle changes and behavioral things that we want our patients to do, then there are drivers for them not doing it. The literature identified a few things too from the provider side. There is this concept, as I mentioned, of psychological insulin resistance, and it comes in the form of biases and fears. Sometimes providers feel like if I suggest this, then my patient is going to resist. They're not going to want to do it, and I just don't want to have to fight with them. My patient is not proficient. It takes a lot of skill to be able to manage insulin in a way that's responsible so that people don't end up with hypoglycemia. And I'm just not sure that my patient is capable, that they're up to the intense monitoring titration that they may need. For some patients, it could be a rocky road getting started on insulin and being able to manage it. And so also fear that this patient is going to cause weight gain, which is going to compound their diabetes as well as make it a problem with their high blood pressure, their cardiovascular disease, and then of course, the hypoglycemia. Also time. I love this picture of the provider in the chair, just frustrated. You're giving me one more thing to do, and I already can't do what you're telling me to do, and now this becomes one other thing. Personnel, I don't have the staff to teach the clients what they really need to know in order to be able to be proficient with their insulin. And then limited knowledge of injection devices for themselves. Things like providers not knowing the right needles to use or the ones that are less painful, and just how to really do it, not having the time to do that kind of training. So these are drivers that even providers bring to the table. And so I just want to remind you, though, that in this changing landscape of healthcare, that now us as providers, we do have a responsibility. We look at now this category 4 that we're entering to 2017 with the implementation of MACRA, this population-based payment. We're now going to be reimbursed for how well our patients do. So population health is here to stay. And we as providers now have to measure health outcomes, and we have to engage our patients. And we're the ones that it falls in our laps on how well our patients do. And so I'm sorry, when I have on my provider hat, I'm right there with you. When I have on my health equity champion hat, then I'm happy for those patients. I'm happy for those folk that are in my family who are underserved and have low literacy level and have to navigate a health system that has, in a lot of ways, has not done them justice. So when we look at population health, you know, it's a balancing act. There's a weight on us as providers, and then there's a weight on the patients, and we've got to figure out how to engage them in their care so that together we can win at this. And at my final slide, it kind of captures it, that when we look at that we do have an issue with medication and other recommendation non-adherent, when we look at our patients with diabetes and other chronic diseases, that we've got to create an environment where we can work together. So that is the solution, finding a way where we put our heads together and come up with a reasonable solution to navigate the barriers. And with that said, I will tag team to the next presenter, Ms. Cheryl Tuttle, who will give us some practical solutions of what she does every single day in trying to work with her patients to engage them and navigate those barriers that they are facing for insulin non-adherence. Thank you.
Thank you. Yes, my name is Cheryl Tuttle. I am a current Associate Program Director with Emory University School of Medicine and their what I call Diabetes Training Academy, and I'm also a reach out community educator for what I like to call LDEP. It's the Emory Latino Diabetes Education Program. So from a CDE perspective, I agree that the reasons for non-adherence can be willing and knowingly, or maybe even unwilling. Is there lack of understanding, lack of instruction, lack of routine? You know, what I'm finding is, you know, you might hear comments in practice that I just forgot. I left my insulin. I don't like shots. I feel better when my sugars are high. You know, I think what I see in practice is adherence really can be a balance of complexity of the treatment and perception of importance. You know, I think that really can be a strategic element of trying to balance the two. You know, as the complexity of the treatment increases, the adherence might be worse, and as the perception of importance, as you know, changes, you know, the perception of adherence might be compromised for a patient. So there's the very happy balance between thinking about what you're expecting of the patient and what they are perceiving as what they have to do in practice. When I'm approaching a patient, I like to think about how you could intervene in the sense of addressing the problematic beliefs with facts and discussion, discuss other potential barriers, maybe educate on the benefits of medication, and simply educate and ask the patient, you know, find out where are they coming from and where does their category of adherence fall into. if it's okay, I would like to address some of the questions. One of the things that I would like to answer is how do we support Hispanic populations with adherence? I see that many Hispanics are very family focused, and I work to be culturally sensitive. And what I work with LDEP is having a bilingual instructor. That way we can be culturally sensitive. We have very culturally appropriate and approachable education materials, and we just kind of assure that literacy barriers are removed.
Thank you, Ms. Tuttle. We have a few more questions. So what are the key community linkages that health professionals can focus on to increase adherence for priority communities?
In the Atlanta area, I know for the Latino community, they really turn to the Latin American Association that has a health and a family-focused branch. Community linkages possibly could come from the Diabetes Association of Atlanta. When we think about what can increase adherence is education and unjudgmental resources that are from a non-stressful clinical situation for the patient. So the Diabetes Association of Atlanta and the American Diabetes Association can definitely be a great community linkage for having that down-to-earth relationship with the patient, and the patient can have a non-confrontational way of educating and asking themselves, what do I want to achieve out of managing my diabetes? There's also the Diabetes Community Action Coalition that is a partnership with Fulton County that really strive to provide access for resources for the underserved, prescription resources, and to really drive efforts to be a support system to let families and loved ones and people affected by diabetes, let them know that they're not alone and that they can have a partner in their making decisions and helping them know that they are making the right decision and that they are not alone, but that they also can have a shared experience with making their decision and knowing that it's a right decision.
Thank you. Our next question, what methods have been successfully used in a community setting, ergo churches, school, workplace, community center, to help educate patients with diabetes?
Yes, two examples I can think of is from a social perspective, the library has been one way that I've seen community resources come together. For example, a diabetes wellness circle meeting occurs in Cobb County at I forget the name of the library, but they're a very successful resource, sustaining participants who come to the meeting. I also had a good conversation where, especially for the Latino community, they're very church-oriented. And I even participated in a very large-scale health fair with a Latino community focus that was based on a church campus. So I see some very successful ways of merging the community and using those community resources to be a way to eliminate some maybe perceived barriers to either the perception of not relating to somebody, or even something as basic as transportation. Those community resources can work really well.
Wonderful, thank you. Our next question, what are best practices for health professionals, community health workers, certified diabetes health educators in order to help patients with their fear of becoming insulin dependent? dependent, excuse me.
Right. Exactly. I would say, first of all, see where the patient is in their level of fear. If they haven't grieved over recognizing their condition, let them grieve and talk it out and accept the condition first. I think that's very important. I don't think you need to sugarcoat it either. You need to have a very open discussion, also asking about emotions and how you feel about it, but the practitioner needs to have a very open discussion about the basic facts of the progression of type 2 diabetes and the fact that it does create inflammatory damage of the pancreas, and often insulin dependence is a necessary target of treatment. But let them know that they're not alone. Let them know that it's not a sign of failure. Let them know that it's another, that it might be another challenge, but that you're going to be there for them and work them through managing another complicated treatment regimen. Encourage them to seek out support groups. If they haven't been in this, if they're going to start insulin, if they've had a life change, that's, one of the 4 guidelines for seeking out a first time or a second referral for diabetes education. Now's the time to seek out a diabetes educator and just support that you are going to send that patient to someone who has the time to talk them through it and to learn about what it would mean to become insulin dependent.
Thank you very much for an informative segment. We will now be moving to Ms. Samos, and she will be discussing the barriers and facilitators to medication adherence.
Thank you. Thank you very much for the presentations we just heard. My name is Kathy Samos. I am based in Dallas, Texas, and I work at the Diabetes Health and Wellness Institute, which is part of Baylor Scott and White Health Systems. And we are a community-based organization. We share a building with Parks and Recreation Rec Center, and also with one of the 9 Baylor Community Care Clinics in the Dallas-Fort Worth area that see both insured and uninsured patients. We are located in South Dallas, which is the most underserved part of Dallas County, and it accounts for 11% of all of diabetes in Texas and Dallas. So we have lots of good ground and good soil to work with, and I coordinate and lead all the education programs that we have. We are an accredited program for the diabetes self-management education. We're one of 2 fully recognized CDC sites for the implementation of the National Diabetes Prevention Program. We have a health equity program through Baylor funding, Baylor Scott and White funding for bariatric procedures, 100% free of charge for those patients with diabetes that meet the criteria to have this procedure. So we are quite busy, and I would like to tag along what Ms. Jackson mentioned, that mostly my role is as a health equity champion through all our programs. And the objective for our brief discussion this afternoon is to talk about and explore 2 evidence-based methodologies to have these conversations about insulin, and I would like to refer to it as insulin adherence, which implies in itself that patients make the choice that they can with education and with the information and with the tools that they have at hand. And the two methodologies that I would like to briefly explore together with you is shared decision making, which is a model that is being implemented in many large-scale health systems, and which it will be part of Medicare implementation, and also part of how those dollars come to accountable care organizations that implement shared decision making. And what it is a collaborative process where patients and providers share decisions and move forward together. And one would think, well, isn't this what they're already doing? Yet what the literature tells us is that there are, on one hand, barriers that providers have, such as time limitation, having to enter all the data and all the information from patients in the electronic medical records, and mostly their own ability and willingness and spirit to have these conversations in a skillful way that will move the patient forward in making decisions that impact their health, and by that also their community, in positive ways. As Ms. Sabrina Jackson mentioned at the beginning, when someone is diagnosed with diabetes, they don't think about in 10 years giving themselves the Christmas gift of amputation. That said, it is a complex paradigm, because we also know from research that the informed or empowered patient, that doesn't necessarily translate into the ability to ask questions or disagree with a practitioner. And the basic driver for that is fear that their care in the future will not be as good or will have barriers because of them raising questions and not being quote unquote an adherent or compliant patient. Now, to be able to use shared decision making as a tool for changing the conversation, there are some skills and abilities, and this is the second methodology that I would like to describe, such as motivational interviewing. And what motivational interviewing, and I also just think that I'm preaching to the choir here, is a guiding patient-centered counseling style that will enhance motivation for change by clarifying and helping the patient resolve ambivalence about their own behavior change. And the goal of motivational interviewing is to identify and resolve this two-mind thinking between current behaviors and their broader values and goals. And when we talk about this, it's motivational interviewing, and yesterday we were doing a class with some participants on today's call that are community health workers working in a partnership which we have with the city of Dallas, and implementing the Stanford model in community in recreation centers. And so something that we were discussing is how motivational interviewing is really not just being nice to people. Because when implementing this methodology, we have a clear direction, and there is intentional strategic movement to go towards the goal. And it certainly is not a technique that is easily learned or a gimmick that we pull out of our toolbox at any time. It is really a style of being with people. It is an integration of particular clinical skills that foster motivation for change, because that's what we want to be able to do through having these conversations, is find what is the patient's own motivation. Because when there is that staggering statistic of more than 1/3 of patients never filling in their very first prescription of insulin and 28% not adhering to this treatment a year after, we're thinking, well, where's the gap? And that's what we want to identify. Where are the gaps? How can we build that bridge? And that's where, and I encourage each of us to become better and more skilled at having these conversations, and knowing that although it is not, this methodology is not a panacea or something we can use always, it definitely drives behavior change. And so in order to have these conversations, we need to be able to understand the patient's point of view. And when we think about the time constraints, and then of course of the physicians, of the providers, I can see why they would rather be directive and say, you know, this is what you need to do. You have diabetes, you need insulin. If not, you're going to get worse. And so to listen carefully and be present, there has to be that spirit of wanting to do that. And we all want patients and our community members to be empowered, and we want them to be empowered to share decisions about their own care. And those of us who work in the community know that it is small conversations through time and small changes through time that allow us in population health to move forward as a group. And in having these conversations, we are creating a partnership. We are starting off from a very strong foundation of respect, of autonomy, of not sympathy, but empathy. And the question that we ask, and this is how we start using the methodology, we start using what we call in motivational interviewing the oars. And the oars, as the oars in a rowboat, it's not a speedboat, but it does move the conversation forward. So when asking these questions, having them open-ended, we want to hear what they have to say, because it benefits us to keep in mind that 98% of the care takes place outside a clinical setting. 98%. So that patient is going to go home and do exactly what he or she believes is best practice for them. So having those open-ended questions, affirming the patients. And when I say this, I'm thinking of patients and people in general, because one of the very positive aspects of using this methodology is that by practicing it in any setting, we start to realize how it really is a way of being, by doing reflective listening, by summarizing, which allows the patient to know that we are actually present and we understood what they are saying. So using these skills and abilities and getting better at it is what will benefit this shared decision making and increase patient satisfaction, and that by itself will lead to better health outcomes.
Thank you so much. Yes.
Yes.
Thank you very, very much for a very informative segment. So now we are moving to open Q&A. So we will be sharing many of the questions from the registrants. However, if you have a question that has arisen from today's presentation, we ask that you submit it in the question pod.
Hi, everyone. This is Sabrina. And I think the question was about best practices maybe for providers to help with non-adherence. I can't remember. It was something along that line. And I can't remember the exact question, but the idea of doing a diabetes distress questionnaire may be helpful for that scenario when you have clients or patients who may be struggling, with this disease burden and the way their lives are going to be changed forever. Having them to do the diabetes distress questionnaire is a really good talking point to start a conversation, for one. So it's a really useful tool for a provider to use. And it will also help to indicate if you need to do a referral for your patient to be able to see a behavioral health provider to help them navigate some of the challenges that they have in their the emotions and, in terms of coming to grips with this diagnosis and the disease process.
Thank you for a very thorough answer. So our first question is, are there studies that look at non-adherence and how it is impacted by patient education?
There is literature, and you, whoever asked the question, and everyone else, we can do a search, and the AADE journal, the American Association of Diabetes Educators, has conducted several studies regarding attendance to the diabetes self-management education and training to an accredited program, and its impact, and it impacts insulin adherence in a positive way. And in general, those patients who are referred and can attend, and Cheryl talked about education for patients with diabetes, and of course we know the challenges and the cost of some of this education and how it's only covered in the primary care setting. We are fortunate here at our Baylor Community Care clinic and diabetes program that we are now doing it free of cost to all patients. So, and we do see a relationship between those who attend all 4 classes, and they are 2-hour classes plus a follow-up with either the nurse, CDE, or the registered dietitian, have better outcomes. And that is one of our actually continuous quality improvement projects for the year, to have those percentages of patients that attend the classes and who improve their A1C.
And Cheryl, could you also just weigh in on the diabetes action plans and how effective they can be in helping to eliminate some of those barriers?
Well, I think what education and coming up with an action plan does is it gives that patient a shared ownership and a collaborative feel for being on board with how they're going to approach diabetes, so that, and also in education situations, rather than say a one-on-one in a cold clinic exam room, they get to have those shared experiences. People speak up, family members can come, they can chime in, and then they can also, everyone can just build accountability and rapport with each other to say, yeah, I'm feeling that same way too, and how did you come across fighting those feelings?
I think there's a role as well, for the diabetes self-management support groups as well that, many people offer after clients and patients have completed the certified diabetes education classes that, often, particularly in terms of when we look at people who don't have insurance coverage, or they may not have that option, but also being a part of a diabetes self-management support group, that also is very helpful in giving people the support they need for the lifestyle challenges that may also arise. So.
Right, and a big part of a truly, supporting and educating diabetes education program is showing that they have given that patient continuing resources. Because where do you go from, the end of your 10 hours?
Right.
And
exactly.
and how do you continue that support? How do you know when to speak up and say, hey, this is going on, or this has changed in my life, and how can you approach that? And that's why resources and support groups are so important.
Great. We're moving on to the next question. With the rising cost of insulin and cost being an access issue, are there any programs that any of the panelists can speak to which can assist patients with regards to the cost as a social determinant which impedes insulin adherence?
Right. This is Cheryl. I found the article, The Rising Cost of Insulin, that was found in several diabetes articles, very, very moving. When you think back from Frederick Banting, he sold the patent for $1 in 1921, and now, as this quotes in the article, insulin is like a $24 billion industry now, and the prices, the insulin, to me, this is my opinion, I think insulin is becoming big pharma, and they're looking for the big, insulin trick that can do everything from, limiting hypo experiences to being longer and more sustaining as like an ultra long-acting insulin. So they're trying to get more and more fancy. Cost is a huge deal. However, you've got Eli Lilly. They're going to be partnering with blinkhealth.com to have a prescription discounted price plan. When you look at a lot of other companies, you've got the blinkhealth.com. Pfizer has RX Pathways. Then you have Sanofi has rxassist.org. So there's, aside from maybe a sliding scale or some kind of federally funded, hospital, like Grady, for example, has a Grady funding, formulary, that if patients have a prescription through the Grady pharmacy, they can get it through a Grady, if they're part of the Grady financial assistance program, they can get their prescriptions for a very low copay. But there are public assistance programs out there, and they generally start with the pharmacy that produces that product that the patient is prescribed.
Okay, wonderful. Outside of pharmacy claims data, are there any methods for tracking adherence?
I'll weigh in on that. I can Yeah, as far as I know, according to the literature search that I've done, the only other way is through patient query, of actually asking the patients about the way they are complying with their medication. And this brings to light, an earlier discussion we had is about trust. You want to try to create the kind of relationship with your patients so that it is a partnership and they know that you are a partner with them in health. I was sharing that I had a recent encounter with a patient who I was doing a health fair and just reviewing her results. She'd recently been diagnosed with high cholesterol, was not taking her medication. She'd now been on a prescription about 6 months, maybe a little longer. She'd been picking up her medication every 3 months like clockwork, but was not taking a pill. And her physician was none the wiser. And so she was shrewd enough to know to get it on time, so at least if there was claims data, it looked for all intents and purposes that she was taking her medication when in fact she was not. And she was willing to share that information with me as a stranger, but probably just knowing that I really, I'm not going to say anything to her about it or whatever. And so I just can't stress enough, the need to have that kind of relationship with your patients so that they do feel comfortable. And I think Katia may have hit on a little bit ago, of not having a non-judgmental kind of atmosphere where your clients know that you want them to be empowered. And I often would say to my patients when I was in the clinic is that I really need this to work for you, because if it's not working for you, it's not going to work for you. And so I not only need the medication to be effective, I need this regimen, this whatever I'm giving you to work for your life, and you're the best person to let me know that.
I would like to add to that. A lot of electronic medical record programs have a way to be modified and tailored to what you're looking for, and I would encourage, if that is something that you want to track in a clinic, talk with your IT people. See if there's a way that you can put in a few questionnaire questions and pull that out, periodically for data tracking. And also, when other providers are looking at that chart, they will see those questions answered. There's tons of medication adherence, short bit questionnaires out there if you just do a Google search. And I think there's more room to incorporate them into electronic medical records and documenting.
Thank you very much. So our next question, and this will be our final question before we conclude. As the title indicates, this webinar was to discuss the health equity implications associated with medication adherence. So essentially, what are the drivers to achieving health equity in relationship to also achieving medication adherence?
Loaded question. Thanks, Sherilyn.
Yes.
Would anyone else want to weigh in before?
Well, I'll just say super fast that it's a complex situation that needs our best thinking hats, and it can be done and will be done because we are those champions.
Yeah, I love it. Yeah, I think, one of the things is that equity is achievable. We haven't yet, but we can. But we have to approach it from a systems level. And I know a lot of people don't like to entertain that conversation, but systems do what they're designed to do. And so part of the wonderful side of healthcare reform is getting at redesign of the systems. The way we've done medicine traditionally has not really worked to eradicate chronic illnesses and to manage people in the way they need to be managed. So with system redesign, it's possible. We just have to stay the course. It's hard. That I will agree to, but I do believe it's possible. So, and you can hear a violin playing behind me, I'm sure.
Yeah.
Sure. Would you want to add anything?
Yeah. No, I agree that it's a systems approach. It is a loaded question. Just equity and balance of health care across different populations, economic situations, belief systems, for different cultures. That's a tough one to handle, but I think as a practitioner, I like to say for trust, just be a team player, recognize the patient you're talking to and be reasonable for their expectations, be understanding to the best of your ability where that patient is coming from, and be sympathetic, and also just be thorough as to prioritizing, I'm getting to the root of problems, and trying to see, I think as we see everybody as individual, then I think we'll break barriers in equity.
Thank you for very thorough answers to that very loaded question. And that brings us to the end of our time, and I thank each of you presenters for a very informative dialogue regarding the topic of drivers for insulin non-adherence in minority populations. And we thank each registrant and participant for attending today's webinar. Again, you can connect with us using Twitter via PriCareMatters and at our website www.primarycarematters.org. The webinar presentation has been emailed to you. However, the webinar presentation and the recording will be available on the Primary Care Matters site, and your post-evaluation will be following in order to receive CE credits and certificates of participation. And we thank you for attending today's webinar, and I hope you have a wonderful day.
Thank you.
Thank you all.
Thank you.